Hi, everyone, and welcome to ABC's of Anesthesia. Now, today I'm with Shady. Now, Shady, you reached out to me and you said you wanted some practice with interviews. And I thought that's extremely generous of you, first of all, because the stuff I'm going to ask you, it's just really important for the feedback I'm hopefully going to give you and the little things that come out of this interview. Well, it's going to be useful for so many people. So thanks very much for volunteering it, and I hope you get a lot out of this as well.
Yeah.
So tell us a bit about yourself and what stage you're at.
Yeah, awesome. So I'm currently PGY 4, going to PGY 5 next year. By the end of this year, I would have had 18 months of anesthetic experience. Currently an unaccredited registrar in Queensland, a
Mhm.
remote or rural hospital.
Mhm.
And we also deal with HDU, so it's a bit of uh,
Cool.
big responsibility, I guess.
Yeah, good. And you're about to go for your interview for anesthetics training.
Yeah, that's right. So I've applied everywhere because I'm really keen on anesthetics, but
Mhm.
I'm going through the Queensland one for now.
Yeah, excellent. Let's get started. So the first question I'll ask you, welcome to your interview. Shadi, tell us a bit about yourself.
Yeah, awesome. So from a clinical perspective, I've been PGY 4 at the moment, going to PGY 5. Next year I would have over 18 months of anesthetic experience, 6 months of ICU and 6 months of NICU and PEDS. I'm really keen on anesthetics, and this year has really fleshed it out of me by doing anesthetics under level 1 supervision for well, now for 6 months, but for the whole year. I've really enjoyed it and it's really been amazing. I'm really keen on teaching. My partner's a teacher, my parents are teachers, so I think it's well within me to teach. And so I'm involved in teaching with that. And I'm also have a keen interest for research. In my spare time, I like to play soccer. I'm really passionate about soccer, and the Euros just happened, and my favorite team, Spain, won, so it's awesome. And I like to play music. I play 4 different instruments, and I play for church in the music band.
Yeah, amazing. Hey, so I'm going to give you feedback on that. So I like that you said that the tell me about yourself question really is it's very open. And a lot of people might struggle with the fact that they don't know where to stop and where to start and how much detail to give. And the way I think of this is, first of all, there's no perfect answer because you don't know what the panel's going to perceive. But I suspect that you've got lots of highlights in there. So first of all, you said you have 18 months of anesthetic experience. That's a highlight. And you correctly kind of said that because I'm like, oh, good, this person is experienced. And if I want people who I can leave by themselves overnight and they can fulfill a roster, that's a really good point to add. It doesn't need too much elaboration, but we clearly know you're into anesthetics, but it shows that you have some competency. You quickly mentioned teaching and research, and I suspect that you have a bit more time, like 20-minute interview for us. It's like 4 questions or 5 questions, 4 to 5 minutes each.
Yeah.
Clarify that before the interview, because in which case your answer could be elaborated. So if you were to tell me what are the highlights of teaching and research
Mhm.
and what you do in your spare time, how would you rephrase your answer?
So from an academic point of view, I'm really keen on teaching. I've been involved. I've done a lot of work in different hospitals in different states. So I've been involved, and that's helped me be involved with different unis. So I graduated from James Cook University, which I'm still doing online tutorials for the university students. I'm also a conjoint lecturer of UNSW. I've done some tutorials with University of Melbourne, and I've marked some OSCEs for final years. And currently in my job with Central Queensland University, doing some teaching for the nursing, but also we do a monthly teaching for our anesthetic PHOs and consultants. And we talk about topics particularly related to the primary exam and going through the NSCA modules for the primary exam. And so that's really been helpful not only to teach, but to be teachable.
Mhm.
In terms of research and
I-
audits,
I'm going to stop you there. With the teaching, is there anything that you've started yourself, something you've initiated?
yeah, I've initiated an ultrasound guided cannulation and arterial line kind of.
Amazing. So to me, right? So when you say, first of all, the highlight is, you said some stuff about which university you're part of.
Yep.
Straight away on it, look, I'm really interested in teaching. I'm a conjoint lecturer with James Cook, and I have an appointment with UNSW. So those are big highlights because that means you got a position that someone has accredited you with. This is not just kind of
Yeah.
low level haphazard teaching. You've done that. The next thing is if you've started something, like a lot of think about what most people do. Most people teach
Yep.
here and there, but you started something. You said, I realized that there was a thing that needed to be done, ultrasound, guided, whatever. And then you went and did that. So that is a massive, big highlight. So I really want you to be able to mention
Yep.
that. just remember, everyone says words, everyone says common things. You've got some standout things, chuck them in there at the very start. Tell me about the other highlights, research and spare time.
Yep. So I'm currently in the lead researcher for a Central Queensland University project for tuning out anxiety in peri-op medicine using music medicine. And so that's something very simple, just putting headphones on patients prior to the operation and seeing if that reduces anxiety. And so we're doing that research at the moment. And I've always been keen on this idea, but it's kind of taken me a while to actually get it started. And we're doing that in Gladstone Hospital, which is a small hospital. And so it's an amazing opportunity to be able to. I
Dude,
really
I'm going to stop you there. So lead researcher, fantastic. You then said a couple of things that diminish what you are doing instead of just selling me big ticket like highlights again. So lead researcher, I'm in charge of this trial. I have recruited this many people, this much data, this much organization. This is where we're at. If you get what I mean, those are the points that make me think, oh, you can do stuff. So how would you rephrase that?
Okay, so I'm a lead researcher in a tuning out anxiety for peri-op medicine using music medicine, and I have incorporated statisticians. We're recruiting at the moment over 100 patients in the peri-op clinic, and we're trialing with different patients' choices of music and seeing if that reduces anxiety. And this is along the side with improving patient experience and giving them a survey post the procedure, and we're using a research assistant to help us do that.
Where are you at with that?
So at the moment, we've put the application through, and we've got an approval for $7,000 through this Central Queensland University.
Amazing. Okay, these are lots of highlights. So this is great. So I'm just going to rephrase it the way I would say it.
Yep.
So I have a real passion for research. I love the idea of, the process of the scientific method to find answers. I'm actually now the lead researcher in, music to decrease anxiety project. What that means is that we're giving people music to listen to and then measuring outcomes of anxiety scores or whatever it is. Now, what I'm really proud about in this is I'm lead researcher. We've recruited over 100 patients, this many sites. We're at this point in our data collection, and we've received a $7,500 grant. To me, those are the highlights. It tells you the heading, what it's about, highlight, and I can now categorically say that you have done more than the other people that I've heard about with research. Okay.
Yep. Okay.
Good. Keep going. What was that thing in your spare time?
Oh yeah, music. So I have a big passion for music, and I play 4 different instruments, which I taught myself. But I play the drums at church in the church band.
Mm-hmm. Yeah, you said 4 different instruments. Tell me what they are.
So I play the guitar. I play the oud, which is an Arabic traditional instrument. I actually learned on YouTube by putting videos in slow motion because I couldn't get the tutor. I play the drums, and I also play the piano.
Look, so this is a potential highlight that you could put in many situations. And you say, look, in my spare time, I really enjoy music. I'm so into music that I actually know 4 instruments that I've learned by myself. The most, piano, guitar, drums, but the most interesting one is an Arabic instrument of this name. And, it's very hard to find a tutor, but I knew I wanted to learn it. So I went to YouTube, I put it in slow motion and I learned it myself. And I'm really proud of this because, this is something I didn't think necessarily I'd be able to achieve. And I went outside the box to achieve this. I think that's a great example. Let's move on because I want to get through as many questions as I can to give you feedback on. Okay, so you're an anesthetic trainee next year, and you're in theatre, and the patient is just a well patient for a lap colleague, and you notice that your anaesthetist, your boss, is just behaving a bit erratically, slurring his words occasionally, just has a little bit of an off look to you. What do you do in this situation?
Yep. Thank you for the question. So I think this kind of flags me.
Just quickly, don't say thank you. It's just the thing. It's wasted words. Anesthetists, generally speaking, hate wasted words. So things like, "That's a great question. Thank you for the question." Just we've got this whole thing that we trained our whole lives to get to the point, and we had all our examiners saying "get to the point." So I suspect that that's wasted words that you don't want to do. I don't know exactly about that, but I'd say that. So start again.
Okay, so it's important to identify that this situation might be an impairment situation for the consultant. although it might not. So I think it's important not to be judgmental, but I believe it's important to ensure that the patient is safe in this situation because the patient is the most important. If I'm worried about slurred speech, either intoxication or drug use or something along those lines, it's important to keep the patient safe. It's also important to keep this confidential, and I believe there's no obvious signs of impairment at this stage. So if I'm able to ask other consultants that have worked with this consultant or nurses, have they noticed anything? Is there an observation that can be done? Is there an audit or a re-audit for this consultant? And then obviously the reporting is flagged. Does this need to be reported to APRA as a mandatory reporting for alcohol intoxication or drug use? But this has to be proven first. And I would escalate care early. And I would document everything very clearly so that if I have a discussion with the head of department or SOT, I would bring the documentation with a written evidence.
Okay. And let's say you're right there. The patient's about to be anesthetized by your boss. What do you do?
And have I confirmed that he's intoxicated?
No, you've got a suspicion, behaving a little bit different, slurred speech, behaving erratically.
Okay, there are two options that I could do. If I'm confident enough, probably more than level 1 supervision.
Let's say you're as confident as you are with the information you have.
So no, I meant like if I'm confident in terms of help, like being there and more than level 1 supervision.
No, you're exactly as you are now, except you're a first-year registrar.
Yeah, sure. I would potentially ask for help. And ask a different consultant to come in the room and explain to them that in confidentiality that I'm suspecting something. I might be right or wrong, but I think for the patient's sake, I believe another consultant should be, because with a level 1 supervision, if I believe that this consultant is impaired, then he's capable of supervising me. And
which consultant would you call?
Either the duty anaesthetist or
yeah, good. Let's say you're in a small hospital and there isn't another consultant, just you and this consultant. Let's say another consultant is well into a case in the next theatre. Who else could you go to?
So I could go to the SOT if he's available. If it's a small hospital,
you'd call the SOT.
Yeah, if he's like potentially in the office. If they're
no, as in literally, there's no one else. Let's say there's no other anaesthetist. It's a small hospital. Yep. No one's available.
Okay, there's other options of calling the head of like ICU, for example, to come and potentially
small hospital. No one who's got anesthetic abilities is there.
I could ask the NUM or the nurse unit manager, and she can potentially, or an anesthetic nurse, or have another anesthetic nurse by the side, because we can offer a lot of help.
Well, if you had no one to ask, hypothetically, but you had to actually confront your consultant, how would you do that?
So I would first confront him in a not judgmental way, and potentially seek information of, is there anything going on in his life? Is there any, just in a way, just to have a conversation, what he's been up to, what he's been doing. And if there are more red flags or orange flags, then I kind of would gauge what has been happening. I'd be really worried about if there was any activity that is away from the code of conduct, which would harm the patient. And then I would initiate the discussion, and I would escalate care, because I think in my role, it's important, even though I'm junior, I can identify problems, but I should not be able to deal with problems. I would could ask for my indemnity insurance. I could ask the doctor's support program or doctor's health advisory services for any advice if I'm reaching my limit.
That's great. Hey, so you did a lot of good things in this question. First of all, when you label something as a thing, for example, you said, I would use the word, this is the situation of an impaired colleague or potentially impaired colleague. I think you used a slightly different language of impaired something, but that's roughly stating what it is. By labeling something as, this is a problem of professionalism, this is a problem of ethical responsibility, this is a problem of an impaired colleague. By labeling it, you now show the person interviewing you that you get this game. So that was good. To talk about your priorities is also useful. You mentioned my priorities is patient safety, and I think I'd add, and the safety of my colleagues and the other staff. Just going to go patient, person, and everyone else is a useful frame, because then again, you're saying useful things. That's the easy stuff. Once you get to the pointy end of things, which is actual confrontation, it could go through any of the things that we've explored now. Like, for example, who would you get? Like, how would you do this? And realistically, this is above your pay grade. It's such a power distance between you and the consultant that realistically, it'd be hard to confront this person. So the easiest thing is duty anesthetist, and you knew the resources. You knew that there is a duty anesthetist, so that's good. If I take that away, who would you get? Great, another anesthetist. If I take that away, who'd you get? Nurse unit manager. If I take that away, who'd you get? Call a friend. If I take everything away, now you're left at the trickiest part of things. And I think there's no question that you will have to confront this, and there's ways to do it. Now, potentially the way I'd say is, I'd actually just tell my consultant, hey, I noticed that you're acting differently. Are you okay? Because you haven't judged him. You've just been concerned about your consultant, him or her. And you said, are you okay? And then you can say, look, I noticed that you're, slurring your speech, and normally you're more sharp than this. Is everything okay? I don't think we should go ahead with the case, because you've now used that PACE approach. You've said something pretty gently, is everything okay? He or she can then admit to that or not, and then, or, excuse themselves. And then you can go all the way to saying, hey, look, I really think something's different here. And we've got a patient, and that could be unsafe. And, I don't think we should start this case until we sort this out. And you'd have, the surgeon there and the nurses there as well. Now that's extremely difficult, but it's very clear that if you think the colleague is impaired, then you can't, you have to do everything in your power. And once you've done that, you've said a lot of good things. Documentation, all the helplines, that this is mandatory reporting criteria as well. So these are all very important things to know, because as a general, we don't want you to be in this position, but we also don't want you to let this thing go, because patient safety is ultimately the most important part about hospital and healthcare best practice. That was good. Any questions about that?
No, I think you put me in a corner, but I know what you were doing. You were squeezing me. So no, exactly. It was good. I think it was
good. Because just imagine in the actual exam, impaired colleague, it could go to any one of those things. It could be as pointy as that, or it could be as gentle as the start of it. So let's a lot of things in anesthetic, we will take you down a road until it's very uncomfortable. I don't know what your interview is going to be like, but who knows? I suspect it could be any range of that.
Yeah.
Okay, another one. You are, let's say, on your pain. You're on the pain round as an anesthetic registrar, first year anesthetic registrar. And the nurse calls you in because they're very worried about this patient, because the patient's heart rate is 160. Imagine you've got a 70-year-old patient 2 days after an anterior resection, with the usual comorbidities of diabetes, hypertension, cholesterol, no other real history. And they've had a resection of let's say an adenoma, so a benign tumor that's quite large.
Mm-hmm.
What do you do?
So I would have this answered by immediately. What I will do short term and long term. And through the immediate, I like to split it through patient, organization, and delegation. So from a patient perspective, I would immediately assess the patient and escalate care early. If I'm worried about this patient with a heart rate of 160, we're looking at an arrhythmia. It could be AF, it could be SVT. So this could be a very critical situation. And it could also be a baseline AF. So it's important to do an ATE assessment. Would you like me to go through the ATE assessment?
Let's say airway and breathing are fine. Tell me about C.
So I would like to examine the patient from a cardiology perspective, listen to the heart, try and get 2 large IV ball cannulas, get an ECG, 12-lead ECG, look at his blood pressure. Is he hemodynamically stable or unstable? Does he need support? And I would then move on to D, which is...
Let's say it shows sinus tachycardia on the ECG. How do you frame your differentials for sinus tachycardia?
So my differentials would be the most common to the least common. I think in this case, in an APS round, he's just had an operation. It's likely to be pain driven, and so that would be the most likely. Sinus also tachycardia could be an infection. He's day 2 post-op. I like to go the 5 Ws, and so wind is probably day 2. He's day 2 here, so he could be a pneumonia.
Just to back up a bit, so you're telling me individual diagnosis. Do you have a framework for sinus tachycardia?
No, I just usually use Vindicate, but it's not
sure.
for sinus tachycardia. Yeah.
It's not sinus tachycardia?
It could be PE, vascular. but Vindicate is just a general
Oh
like
yeah, like neoplasm,
one.
infection, trauma, that kind of stuff.
Yep.
Okay, no, keep going. Let's see how you frame your differentials.
Okay.
What do you think I want to hear from you when I say, what's your framework for differentials of sinus tachycardia?
So you probably want to hear what's, I guess, how I like how I organize sinus tachycardia in my head.
Yeah, because imagine you got this sinus tachy patient and it's a patient who's old with lots of differentials. If you're going to miss one of those differentials, that's a problem for the patient and definitely a problem for the system and me. And overnight, I don't know if you've cleared everything. So you're going to tell me sepsis, pulmonary embolism. Like this is not satisfying for me because I'm like, oh, how are you going to rule out the 50 other diagnoses for this? So yeah, I mean, this is putting you on the spot, but putting you on the spot, but also, can you come up with some kind of system that you've seen before that might be able to rule out the things that I really care about ruling out?
I don't know off the top of my head, but I would go through Vindicator.
Yeah, you can, but I think because I think there's a system that you already have known about with ALS that you could probably use.
Uh, so like A to E, no.
I
Um,
mean, hey, you could use that because let's say the things that we're going to care about with this answer is that you don't miss the things that are going to kill the patient.
yeah.
And ALS is all about is a patient going to die from something? So yeah, let's see what you come up with.
Okay. Well, I would probably like to go through the Vindicator just because
Absolutely go for
but from a vascular point of view, I'm worried about a PE.
it.
I'm worried about, yeah, probably PE is the only thing that I'm worried about at this stage, but it could be also an MI from a vascular cardiology point of view.
Mhm.
Um, Infection, very likely to be sepsis post-op. Neoplastic, unlikely. Drugs, there could be, he could have some sort of drug reaction, anaphylaxis. He's on the APS. Um, Iatrogenic, no, unlikely. Congenital, unlikely. Autoimmune trauma or endocrine is also unlikely in this case.
Well, what are the four H's and four T's?
Oh boy. So we got hypoxia, hypovolemia, hyperkalemia or metabolic syndrome, and hypovolemia. Did I say that?
Beautiful. And hypothermia.
Oh, hypothermia.
Beautiful.
And
T's.
all these toxins, thrombin, tamponade, and tension pneumothorax.
And just say thrombus, pulmonary or cardiac rather than thrombin. Don't say metabolic syndrome because that's a specific thing. Say other metabolic problems would be useful, say like BSL. Hey, that's good. The other way I could do it is, system by system. So, CNS problems, cardiac problems, vascular problems, lung problems, but there's pretty much any system that's going off can cause a sympathetic response that causes sinus tachy. I like the 4Hs, 4Ts because it's an existing thing that everyone knows, and they all can cause tachycardia, and it can all kill people. And if you've ruled out each of them, like literally back in my resident days, if I ever got a Met call or some kind of urgent clinical review, I didn't care what the patient was, whatever the problem was. I went, could it be one of these 4Hs and 4Ts? Let me rule these out. Let me write this down, and then I can be reassured that I've ruled out the red flag stuff, and now I can think about pain and the usual common stuff that might cause tachycardia.
Yeah,
That's good. So you did that well. So first of all, I like that you had some kind of you're focusing with patient organization and delegation. Not a bad framework because a broad question like this may require a broad framework. So I do like that. And you went straight to patient, which is where the money was in this. You attended. You thought about your differentials, and some of the serious things are primary versus secondary tachycardias, primary meaning SVT, AF, and ventricular tachycardias. So you very rightly thought about those things as you're attending the patient. You did an ATE approach, and I didn't need you to go through the ATE, but I did want to see what you'd say about circulation. You correctly got access, and you thought about the ECG and the measurements, thinking that if this patient's hypotensive, that means everything. Tachycardia and hypotension means there's a serious problem, whether it's a primary or secondary tachycardia. So that was great that you did that. And you got the ECG. If you don't get the ECG, you cannot diagnose this. So that was really great. So imagine I could have given you SVT, hypotensive, now we're doing ALS tachyarrhythmia pathways. Again, this interview isn't about medical knowledge, generally speaking. So I suspect that most of the time when, in any kind of anesthetic application interview, they're asking you clinical questions. They need basic framework stuff, and we're not going to go into ALS and things like I don't think that's appropriate because everyone has varying anesthetic experience up to that time, and nothing's mandatory. So it'd be kind of unfair to ask a very airway specific question or anything other than what you'd expect a resident to know. Once you got to that, I gave you a diagnosis, and then I want frameworks, because frameworks, like I mentioned, I want you to rule out everything, especially the serious stuff. And good, that was good learning. Cool. Let's ask you one more question. Tell me a situation where you weren't particularly good, or you were criticized about something, and the things you went through to fix that and do better into the future.
Yep. So I have been given feedback recently that I am, not recently, sorry, regular feedback that I am very softly spoken and not very assertive. And in fact, I failed my ALS because I wasn't assertive enough in the scenario. And they said that I was too nice or softly spoken. So I took that on board. And what I did was I would just go in my room and try and be, assertive and try and say things very directly. Just do an ALS scenario in my room, basically. And one of my mentors, I had a chat to them and I asked them, how do I do this? And they also had the same problem when they were training. And they said that you have to keep a journal book and a log book and try and improve of that through the experience. And I, went back home, practiced. The next day I passed my ALS. And since then, it's now become one of my strengths. I've ran a couple of code blues here where I'm working at the moment. And I've just, when I'm in an ALS situation or a anesthetic emergency situation, I become a different person and I try and delegate roles to everyone and become more assertive. And although I was upset at the time, I think learning from your past experiences and and feedback, constructive feedback is very important. And since then, I've really worked on being assertive, giving instructions and delegating roles.
That's a really good one. So the first thing that was genuine. The fact that you were able to say that you failed at something, I think that's really big. So a lot of times people will say really crappy kind of weaknesses or criticisms about how they were staying too late and coming in too early, whatever. I think this is a good one. It's genuine, and you went through a process. You were practicing things out loud. You're learning things. I like this example. Initially I thought it might not be a good example because I think you were saying something like you were just not assertive enough, and that was it. But you backed it up with an actual problem that you had. So yeah, this is a good example, and concrete examples, like to actually say, like you could potentially tell an actual story to really make this sharp. Like, so I might just paraphrase and say, Look, one of the things that I really struggled with was being assertive. Especially in like ALS scenarios. I remember actually failing my ALS exam because and the feedback was I wasn't assertive and I wasn't, doing whatever. I took this on board. I ended up talking to my mentor, getting out of, having a plan of strategizing on how to do this. The action I did was regular practice in front of the mirror, learning the ALS protocols. Then the next day or whatever time frame, I went for the assessment and I passed. And I was extremely happy with this, but it had many really good ramifications since then. I'm in a small hospital. Often I'm the senior doctor running code blues. And in this one specific incident, we had this patient came in, and the feedback I got was that I was delegating, I was authoritative, I stood at the head of the bed, and I was very, I did all these other things for, you might put in some words like my non-technical skills. The feedback from the nurses was really good. I was telling people what was going on. I was summarizing the situation. I was closing the loops. I was putting things on the board so that people knew what was going on. And you can label these examples to color a scenario, especially with examples of things that anesthetists like, all the anesthesia non-technical skills. So if you ever look up CRM, Crisis Resource Management, Life in the Fast Lane has a really good summary of that. For this particular thing, you might be able to chuck in a few of those because CRM is a buzzword, Crisis Resource Management is a buzzword, and there's a whole bunch of specific kind of things related to that are useful.
Was that crisis resource management in Life in the Fast Lane?
Yeah, if you just Googled CRM or Crisis Resource Management, Life in the Fast Lane, they've got a really good summary of a 2005 article by Roland Gabber that had a number of different points about all the non-technical stuff that makes crises run well. Really important. It's something I think about a lot because it's what makes a really, besides knowledge, after knowledge, it is CRM that makes good outcomes happen.
Yep.
Hey, Shady, so I think that's probably how much time I've got, but hope that was useful. Do you have any questions at all?
No, it's very helpful. Thank you for finding the time to do this. I really
No,
appreciate it.
no problems at all. And thank you so much for coming on the channel and doing this. I think obviously it'll be really helpful for people to this obviously this is important for your exam, but I think this style of communication it's for everything. It's for this interview. It's for your next interview. It's for your consultant jobs. It's so important to have this skill. I don't know how much an interview really matters and tells us about a person, but I think the process of going through the interview for yourself is really important. That self-reflection is learning how to communicate, and it's learning how to present yourself to a panel of people who are judging you, and that's what life is, right? Cool. Thanks, Shady. We'll sign off there. Please share with anyone who might be interested in this kind of content, and we'll see you all next time. Thanks. Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.